Madam Speaker,
Dr. Madara.
Mr. President, members of the board, delegates, and guests. For more than 170 years, the American Medical Association has been at the forefront of medicine. From creating the first code of medical ethics and establishing professional standards, to creating the coding backbone for tracking medical procedures, from sweeping public health campaigns that sought to end smoking, to creating, as you've just heard, the medical school of the future, and building partnerships with other leading institutions like the CDC and the American Heart Association, aimed at diabetes prevention and blood pressure control. These proof points show how the history of the AMA is intertwined with the history of American medicine. In 2012, it was really exciting to describe our moonshots, our comprehensive plan to transform medicine around three strategic priorities: improving health outcomes, creating thriving physician practices, and creating that medical school of the future. We'll update many of those successes again at the annual meeting. Now, Dr. Barb outlined how the AMA advocates on behalf of physicians and patients using our policy portfolio to shape legislative and regulatory decisions. Our voice is a mitigating force for national chaos that we seem to tilt toward as of late. The AMA's critical work to stem the waterfall of disturbing legislative healthcare proposals, now that rightly occupied much of our time and effort. And it was lauded by many from many quarters. And it was lauded for being principled, which, by the way, it happened to be. It exemplified strong leadership in medicine. But I'd like to pivot a bit and use my time today to focus on longer timelines, on problems that are fundamentally important but less apparent in the daily headlines. Now, I know you're all familiar with Google Earth and its use on your smartphone and iPad. It's really fun to see where we live, then zoom out to our neighborhood, city, state, country, and finally see our place in the world. To go from this granular view to the broadest view possible. I actually see a couple smartphones, so you're following along, and thank you, that's great. So let's zoom out for a moment to examine the longer game. There are long-term needs that need to be addressed, and they need to be addressed regardless of what specific future healthcare architecture we find ourselves in. For example, we all know that clinical data sets need to be better organized for physicians, and that electronic health records have to better assist in organizing what we need. We have a pressing need for interoperability, but interoperability defined by being able to transfer clinical meaning and meaningful data objects, not just individual clinical data points. Currently, we confront oceans and oceans of data, but only puddles of clinical meaning. And even if our data were better organized to be more meaningful, we lack the appropriate utility for the secure and timely flow of data, what experts might refer to as clinical data liquidity. So here's the problem. You see a patient who may have hypertension. His blood pressure is elevated. But is this real or a white coat effect? Or related to the fact that he just ran across the parking lot from Starbucks? Now, luckily during the visit, given our current state of excellent fluid interoperability, you're able to effortlessly capture his blood pressure readings in an organized digital way from another institution. I'm just kidding. You can't do that. What's available to you isn't conclusive. And although he's been following his blood pressure at home, none of those data are connected to and embedded in an electronic record in an organized way. Instead, he scribbled his recordings down on paper somewhere, and he recalls that the top number always being around 125. But on second thought, maybe it was 155. His handwriting's not that good. So you bounce around the electronic record, history here, renal function there, and you're basically searching for those puddles of meaning. So what's the AMA doing to address such needs? Needs that will become more urgent as the number of data elements grow. Our work at the AMA in the last 4 years on hypertension has led to a greater understanding of the complexity in evaluating this simple condition. For example, hypertension alone requires roughly 75 data elements to provide a complete picture of the patient's state with regard to this diagnosis. However, these data elements are scattered throughout the electronic record, and shockingly, a significant percentage of these vital data elements cannot be consistently captured at the level we need. Self-measured blood pressure readings that automatically connect to and become organized in the record just being one example of that. Data are so critical to a physician's understanding of a patient's health. And when elements take time to track down or are missing, it's like the fable of the blind men touching the elephant. You know, one feels the trunk, another the tail, one the ear, and each one of the men has on his mind some different image. And that's what healthcare data are today. Each of us are touching data bit by bit, then spending time trying to conceptualize the elephant. For everyone else, they're living in an information age, and yet even for that small pool of digital devices that we have been using that are well characterized, validated, evidence-based, and actionable, even the best are not connected. And the data that's ultimately entered into the record tends to be not organized in any useful way, to say the least. Instead, you're in that ocean of disconnected data points that seem to lack context or organization, and that is, seems to lack true conceptual meaning. And your EHR currently isn't going to help you much. You're on your own. Go in there and find those puddles. This is an obvious pain point for physicians, and it's why the AMA has launched the Integrated Health Model Initiative, IHMI for short, an endeavor to create a common data model throughout healthcare that is unlike anything that exists today. Our allies in the field are calling our IHMI solution dearly needed and also incredibly bold. And it certainly could be a game changer in healthcare delivery. IHMI can be accessed by any provider, group, or organization, expert groups that propose data element models that then move to conceptual solutions. You know, that's to say, assembling elements for clinical meaning. Now, delivering on this promise is not going to be easy and it's not going to be quick, but physicians aren't the type to shy away from such challenges, especially when the potential is so great to transform our practices. We launched IHMI last month following 2 years of intensive work inside the AMA. And we're delighted that those from various sectors who've already joined us have expressed great excitement for this project as well. And those collaborators include IBM Watson, Intermountain Healthcare, Cerner, the American Heart Association, and several more. This initiative also fills several other needs. Not only filling existing gaps, but also serving as a platform that will be patient-centric, capturing patient goals. That's one example. It seeks to assemble data elements into meaning conceptualization of the patient's current state. You know, it's been said that data are the oil of this century. And so harnessing the power of health data in a way that is both efficient for the physician and improves patient care is an enormous and important challenge, and one that should be led by physicians. And the result has to be a data solution that is easy and useful for physicians. IHMI seeks to accomplish this in 3 ways. Number 1, it will deliver better organized and more relevant information about a patient's clinical data, including social determinants and patient's goals, and deliver that into the hands of physicians at the point of care. It will provide meaning and context, not just data, though all the data will be accessible. It will simply be better organized so that the elephant is obvious. Number 2, it will create collaborative digital communities to identify costly disease burdens and identify solutions through a neutral, physician-led validation process. Our own internal work will, as you would guess, have some focus on prediabetes and hypertension. And lastly, number 3, IHMI establishes a common data model that can be more easily shared across health systems, allowing data elements from one vendor platform to be meaningfully transferred to another. This achieves interoperability, and not simply by being able to share limited data elements, but by the ability to transfer real clinical meaning. And you can learn more about IHMI on our website. IMHI is but one critical node in our innovation ecosystem. There are several others, but you'll be happy to know that mercifully I'll just deal with one. So you're welcome for that. And I select this other because, as I foreshadowed earlier, it deals with data, as does IHMI. The ambitious innovation studio we helped launch in Silicon Valley, Health 2047, now has 2 years of solid work behind it. If we are successful in IHMI in organizing clinically meaningful data in a way that's tailored to help physicians and provide conceptual meaning, and can create interoperability for these meaningful data, then we need what experts call a data liquidity system, an inexpensive pipeline for data flow. And you might think of it as a utility for healthcare's data transport. And this is exactly the thinking that created this specific Health 2047 project. And with some early developmental success, it has just spun off as its own separate company. The project currently goes by the code name Switch. The transformational promise of Switch has had sufficient gravitational pull to attract senior leaders and engineers from companies like GE and Intel who have moved over to this company. Switch is a subscriber network that enables secure, permissions-based sharing of health data among patients, physicians, and others in the healthcare sector and technological sector based on permissions. It will have the capacity to serve as an inexpensive utility for data movement in healthcare. And that's not unlike our city's power grids or the underground water supplies of our cities. Another way to think about Switch is it will bring to our healthcare sector what the currency utility called SWIFT has done for the financial sector. SWIFT is a platform for permissions-based secure transfer of currency and other financial data internationally. The beauty of both IHMI and switch is that either could be transformative alone. But together, if both successful, you can hardly imagine the impact these would have. These tools will be in further development over the next 2 to 3 years. As I said at the beginning, the AMA has many immediate projects because physician needs are very acute. The crafting of legislation, emerging regulatory frameworks, eliminating some of the common frustrations that contribute to physician burnout, as Dr. Barb outlined, these are now problems. But while we do this important and urgent work, we simultaneously need to keep our eye on the future by taking on some of the biggest and most difficult problems. Our immediate impact work, our now work, as well as our work looking into that future, do share a common high-level goal: to extract physicians from a good chunk of the mind-numbing administrative and data entry chores that you face, and to shift that currently misused time to what you are trained for, time with patients. I've noticed something wonderful over the last few years in strategic discussions with many leaders in different healthcare sectors. Over and over, I heard that real solutions need a trusted and neutral player at the center if transformative change is going to be achieved. It needs a natural convener of ideas and objectives. And that's us. We're Switzerland. But more than that, these leaders from other sectors are beginning to appreciate that the truth of healthcare is to be found starting at the patient-physician interface and not at the administrative level. As one industry leader recently put it to me, quote, "Physicians are the knowledge force in the field, but everyone tries to manage around them, and that's where we get off track," end quote. His point was that physicians need to seize a more central role in crafting healthcare. And that's why the work in the AMA innovation ecosystem, such as IHMI and Switch, starts by flipping that standard model of development. It starts at the patient-physician level. You have to get it right there first, before moving on to administrative and other system requirements. Flipping the model. We need to flip the model because physicians are the knowledge force in healthcare. We are the ones leading entrepreneurs and industry to the pain points in healthcare. And we are the ones responsible for creating a system that continuously promotes the art and science of medicine and the betterment of public health. And you know, to get there, we just had to zoom out a bit. Thank you.
Thank you, Dr. Madara.